All right. Welcome back to Neuroclarity, the podcast where complex neurology becomes crystal clear. I am Onowari Victor, your host, and today we are diving into something foundational but often underappreciated: the arterial supply of the brain. We are going to see how this critical knowledge ties into real clinical scenarios. This understanding will give you a solid framework for interpreting stroke patterns and vascular lesions, just like the three cases we'll walk through later. I must add that our cases are derived from Cheng Cheng's comprehensive review of clinical neurology. We are currently in chapter 2. We've done questions 1 to 23, and we will be doing 24, 25, and 26. Let's begin. Understanding the arterial supply of the brain. Let's start with the cows. Yes, cows. Not the cow that moves. No, 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 no. The Circle of Willis. Cows. Get it? The Circle of Willis is the brain's safety net of arterial connections that supplies oxygenated blood to every corner of your brain. It is a polygon-shaped vascular ring at the base of the brain that connects the anterior and posterior circulations. Let's break it down. The anterior circulation originates from the common carotid arteries in the neck. Each common carotid artery bifurcates around the level of C3 to C4 into the external carotid artery and the internal carotid artery. The external carotid artery supplies the face, scalp, and the skull, while the internal carotid artery enters through the skull through the carotid canal in the temporal bone. As the internal carotid artery enters into the neck, it gives out no branches. It enters the carotid canal, passes through the petrous portion of the temporal bone, continues through the cavernous sinus, and then emerges into the subarachnoid space, where it gives rise to several key branches. Those branches includes 1. The ophthalmic artery, which supplies the orbit and the eye. 2. The posterior communicating artery, which connects the anterior and posterior circulations. 3. The anterior choroidal artery, which supplies, hold on, what structures do the anterior choroidal artery supply? Did you say posterior limb of the internal capsule, optic tract, and choroid plexus? If you said that, you are absolutely right. The anterior choroidal artery supplies the deep structures including the posterior limb of the internal capsule, the optic tract, and the choroid plexus. The internal carotid artery then bifurcates into the anterior cerebral artery and the middle cerebral artery. The anterior cerebral artery has many branches, and the neurosurgeon will tell you it has an A1 segment, an A2 segment, an A3 segment, an A4 segment, and an A5 segment. But let's keep things simple. In this podcast, we will talk about the A1 and the A2 segments. Let's leave 3, 4, 5 for the neurosurgeons. The A1 segment originates from the internal carotid artery and terminates at the anterior communicating artery. The A2 segment starts from the anterior communicating artery, and then we have its bifurcation into the pericallosal artery and the calloso-marginal artery. The pericallosal artery runs along the corpus callosum, while the calloso-marginal artery courses within the cingulate sulcus. The anterior cerebral artery supplies the medial portion of the frontal lobes and the superior medial parietal lobe, including the leg area of the motor and the sensory cortex. Can we remember an artery we call the recurrent artery of Hübner? Do we recall what it supplies? If you said the head of the caudate, the anterior limb of the internal capsule, and parts of the putamen and globus pallidus, you are absolutely right. The recurrent artery of Hübner arises from the proximal A2 segment and supplies the head of the caudate, the anterior limb of the internal capsule, and parts of the putamen and globus pallidus. The middle cerebral artery supplies the lateral surfaces of the cerebral hemispheres, especially the motor and sensory cortexes for the face and upper limb and the dominant hemisphere's language areas. It divides into the superior division and the inferior division. The superior division heads towards the frontal lobe, while the inferior division heads towards the temporal and parietal lobe. It gives rise to lenticular striate arteries, small perforating arteries that supplies the basal ganglia and internal capsule. These arteries are prone to lipohyalinosis and are common sites for lacunar strokes. That's all about the anterior circulation. Let us talk about the posterior circulation. The posterior circulation begins with the vertebral arteries, arising from the subclavian arteries and ascending through the transverse foramina of cervical vertebrae, usually C6 to C1. They enter the cranial cavity via the foramen magnum and merge to form the basilar artery at the pontomedullary junction, which is a fun name for the junction of the medulla and the pons. The basilar artery gives rise to the anterior inferior cerebellar artery, the pontine branches, the superior cerebellar artery, and the posterior cerebral arteries. The posterior cerebral artery supplies the occipital lobes, the inferior temporal lobes, the thalamus, the posterior limb of the internal capsule, and parts of the midbrain. Major branches include the parieto-occipital artery, the calcarean artery, which supplies the primary visual cortex, the posterior choroidal artery, which supplies the thalamus, choroid plexus, and the posterior corpus callosum. Remember, we have the communicating arteries, which includes the anterior communicating artery and the posterior communicating arteries. The anterior communicating artery connects both anterior cerebral arteries. This is a side note. It is estimated that only 30 to 40% of adults have a single communicating artery, and two or more connections are present in majority of population. This is a well-known fact to neurosurgeons, but for the ease of our understanding, let's stick to one anterior communicating artery. The posterior communicating arteries connect each internal carotid artery to the posterior cerebral artery. Together, these arteries create a redundant loop, and if one pathway is blocked, others may compensate. But what if they don't? Well, that's where localized infarcts begin to paint a very specific clinical picture, and that's exactly what we're going to look at in our cases today. Let us jump into our first case. The question is, which is the abnormality in the MRI shown in figure 2.7? Let us take a look at it. Options A, absence of the left vertebral artery. Options B, basilar occlusion. Option C, left MCA occlusion. Options D, left ICA occlusion. Options E, fetal posterior cerebral arteries. So what's the correct answer? The correct answer is D, left ICA occlusion. Here's why. The MRI in this case shows absence of the internal carotid artery on the left. Interestingly, the left MCA is still seen, but it is being supplied retrograde via the anterior communicating artery. A beautiful example of the Circle of Willis at work. Both vertebral arteries and the basilar artery are intact, ruling out the options A and B. And this isn't a fetal PCA variant because PCAs are still arising from the basilar artery, not the ICA. Next up, question 25. Which of the following is incorrect regarding the anterior choroidal artery? A. It is a branch of the ICA. B. It supplies the posterior limb of the internal capsule. C. It supplies the anterior limb of the internal capsule. D. It supplies a part of the geniculocalcarean tract. And E. It supplies the choroid plexus in the lateral ventricle. Correct answer is C. It supplies the anterior limb of the internal capsule. That's wrong. The anterior choroidal artery arises from the ICA, the internal carotid artery, just above the origin of the posterior communicating artery. It does not supply the anterior limb of the internal capsule. Can we recall the blood supply to the anterior limb of the internal capsule? Did you see the recurrent artery of Hübner and the deep branches of the anterior cerebral artery? If you said that, you are absolutely right. The anterior choroidal artery instead supplies the posterior limb of the internal capsule, the internal segment of the globus pallidus, the optic tract, and part of the geniculocalcarean tract and the choroid plexus of the lateral ventricle. Let's go to our next case, question 26. A 49-year-old patient presents with acute onset of neurological symptoms. A cerebral angiogram is shown in figure 2.8. Which is the abnormality seen in this angiogram? So, let us take a look at the angiogram. Options A, left MCA occlusion. Options B, left vertebral artery occlusion. Option C, anterior cerebral artery occlusion in the A1 segment. Options D, left ICA occlusion. Options E, this is a normal angiogram. The answer? This is a left MCA occlusion. Let us explain. The catheter angiogram shows no contrast filling beyond the main trunk of the left middle cerebral artery, and this confirms an MCA occlusion. The internal carotid artery fills normally up to its terminus, and if you take a look at this, you can see that we have here the petrous portion of the internal carotid artery. Going up in here, we have the caverous portion, and in fact, this looks like a branch of the internal carotid artery called the ophthalmic artery. And in here, we can see the anterior cerebral artery, but we do not see the middle cerebral artery. There is some sort of occlusion in here. Now, since this was an ICA injection, we can't comment on the vertebral artery in this image. Once again, option A is correct. Left MCA occlusion. Understanding the arterial anatomy of the brain allows you to localize lesions, recognize patterns, and make high-stake decisions quickly. Whether it is an internal carotid artery occlusion with collateral supply, a tiny anterior choroidal artery infarct causing hemiparesis, or an MCA trunk occlusion visible on angiography, you now have the vascular roadmap to interpret these findings. Thanks for tuning in to NeuroClarity. Until next time, stay curious, stay sharp, and keep learning. Bye for now.